Okay, so thank you. A very, very nice introduction. And you might ask why I'm talking about the British Heart Foundation Data Science Centre to an audience of researchers interested in mental health. And that's because through some of the infrastructures that we developed, which, to be honest, from my perspective, were developed with generic uses in mind, but driven by cardiovascular disease and COVID, actually, as it happens, because those were great opportunities. There was funding and there was a perceived need that everyone bought into. I always had in mind that a lot of what we were putting together would be extremely helpful and pertinent for a broader range of uses. And we had additional investment through other sources from HDR UK's data and connectivity study and various other sources to build more of a generic offering. Many of you will be familiar with HDR UK more broadly, and obviously DataMind is a part of HDR UK's sort of infrastructural offerings, with its mission to bring data together to help improve people's lives, and with the vision that these types of data analyses should be informing all sorts of aspects of healthcare, public health, biomedical discovery science, and so on. And that an ambition has always been from the get-go that this should be something that scales readily, not only in terms of population size and coverage, where obviously investigating rare disorders and disease subtypes and multiple epochs of time, for example, requires very large-scale studies, but also that to achieve that scale with diversity and detail and across the lifespan is something that has been at the heart of HDR UK's ambition, and I would say we're some way along that journey. So in terms of the data sets that HDR UK in general is trying to enable access to and use of, there are a whole stack of data sets that are generated through day-to-day routine activity within and beyond the health system, the NHS in the UK. There are many data sets that are brought together and collated nationally. This has been the case for many years. They have been traditionally pretty difficult to link together and pretty difficult for researchers or even the NHS itself, even the chief medical officer, for example, to get a hold of and generate insights from readily. And so that's a problem that is a real challenge, and it feels like it's, at least in part, HDR UK's duty to try and fix that. And we've gone some way towards fixing that, but we're very much aiming to do more in that space. Then there's data that is not currently collated nationally, but tends to be held regionally, and in particular more granular data where it's difficult or impossible really to build a complete sort of national data pool of, for example, all the images that are captured in NHS routine activity, but that provides granularity that's really important for some studies, or all the free text data. And there are others in this room, notably Rob Stewart, who have done a huge amount of work on surfacing structure from reams of unstructured free text data, and who would argue that 80% of all the information is buried in those places and isn't currently coded up and returned in national returns. And then a lot of laboratory data systems, and I could go on, but these are regional data assets, which currently we really don't have a national picture of. Hopefully some of the investments going on within the NHS in the coming months and years will help with that, fingers crossed. And then there is health relevant data, and we've already heard about it, for example, through eChild earlier on this afternoon, a really great example, highly health relevant data that's got nothing to do with the NHS, but it's got everything to do with health. And linking all of these different aspects of healthcare data together is when the magic really starts to happen. And it gets even more magic when you can link all of the data in the top half of the slide to data that's generated outside of administrative activities. So research generated data, large scale trials increasingly and rightly are dependent on the ability to link to these large scale administrative health data sets to identify relevant participants for trials and to follow them up longitudinally over time. Exactly the same is true of cohorts. And I've shown two of the most prominent examples because it's worked quite well for them, not excellently well, but quite well. It's a great model, but it is not working at all well for all the smaller cohorts and trials that really could benefit enormously from better linkages between the top and the bottom half of this slide. And then there's data that is generated through day-to-day activity, watches, apps, club cards, and weather monitoring, and air pollution monitoring, and so on, where again, it's kind of quite interesting in and of itself, but really, really interesting and really transformatively informative if it could be linked to the top half of the slide. So the BHF Data Science Centre is kind of embedded in that HDR UK soup, and with all of that ambition wrapped up inside it. We started out the beginning of January 2020, so we very quickly was sort of plunged into pandemic mode, and the whole team of about 25, 26 people was employed and brought on during the pandemic. It's been incredibly successful. We're distributed all over the country, and every now and then we meet in New York or somewhere like that, somewhere near the middle. With investment from the British Heart Foundation. At the time, this was the BHF's biggest single investment. It's been trumped subsequently, and we've done quite a good job of leveraging additional investment on the back of that. Real hats off to the BHF. I mean, obviously it's a big charity, but it stuck to its guns throughout the pandemic when its resources were really under a significant challenge. I think it's very pleased with seeing how the investment is enabling the cardiovascular research community and indeed beyond to make the very most of some of the health data assets that there are out there. So we have a team of sort of scientific leadership team. So myself and a bunch of associate directors, we're about to take on a deputy director as well, because my role has expanded. And what's important about this bunch of individuals is that, well, only one of them is a cardiologist, and it's a mixture of clinicians with data science interest, but also a computer scientist, a biostatistician, a radiologist, a clinical trials methodology expert. So representing quite a lot of diversity, which is appropriate for this sport, which, as you know, is an interdisciplinary team sport. And we have a great operations team with project management support, PPIE, comms, all of that covered. And then we have also grown a team of 8 health data scientists who are specialists in the management and repeatable curation and analytic pipelines to support quite a lot of the researchers who we've been enabling access to data for. And that's been really critical, really important, and a great pleasure because they are fantastic. So we have a number of thematic areas of activity, the first of which I'll focus on most, which is all around better access to and use of the nationally collated, structured, coded data, primarily from the NHS at this stage, using COVID as a major driver. We've also got other themes around unstructured health data with the focus on imaging, personal monitoring data, what we call computable cardiovascular phenotypes, but it's kind of algorithmic constructions of largely code lists for cardiovascular phenotypes, but very similar to some of the work we've seen on mental health phenotypes earlier from this group. Some really important work on enhancing cohorts. If I've got time, I'll mention that later, and work on encouraging cardiovascular trials that can use routinely collected data for planning, recruitment, and follow-up, working in partnership with organizations such as NHS DigiTrials. And we've also been building some data science catalysts, so partnering with other charities, Diabetes UK and the Stroke Association have made investments into the Data Science Centre to sort of beef up their areas. And that has led to the concept of similar investments within Health Data Research UK. For example, we're working with Asthma Lung UK now to build something similar around respiratory diseases, but using a similar set of structures. So trying not to reinvent the wheel, trying to build on top of some of the bases that have been put in place. So let me tell you a little bit about our work on nationally collated, structured, coded data, which I think is one of the main things that Anne was referring to earlier. So as you probably know, at the start of the pandemic, there was really no trusted research environment in England to be able to remotely access population-wide linked health data from multiple sources. NHS Digital, as it was then, didn't operate in that way. It disseminated data and it didn't do an enormous amount of that, certainly not at population scale. It didn't have a mechanism for doing that safely. There were trusted research environments in Scotland and in Wales, and arguably Wales was then and continues to be the most successful in terms of the diversity of data available and the speed with which it was accessible. We wanted to work to put in place something similar for England, and we used COVID as a great sort of driving motivator and worked in partnership with NHS Digital, now folded into NHS England, to put this in place. This took quite a few months to build and a lot of conversations and partnerships. and investment of time and energy and so on, but it now exists. And we are the sort of the BHF Data Science Centre bubble within it, which has become broad and supports a lot of research, all currently with a COVID twist. Was the first sort of instance in that TRE. There are now a number of other instances that have grown up with very similar data sets involved. So you can see COVID-19 specific data sets, all the HES data going back some decades, death registry data, similarly, a primary care data set that covers the whole of England, doesn't have all codes within it, and there are gaps. There are some gaps from the perspective of mental health, which are unfortunate given how important mental health is in the context of COVID-19. But anyway, there are gaps for now. There's a great community dispensing data set, so lots of information on dispensed medicines and various other bits and pieces. And the mental health data services data set is now linked in there, as is the IAPS data. So I think there are some really great opportunities, even if you can't answer every question, to address some important mental health questions using these data. And some cardiovascular specific data sets. So just so we're supporting a lot of research, and by doing all the kind of heavy lifting, getting all the approvals in place, and allowing many institutions across the UK to join this, and by setting up similar sets of approvals with Scotland and Wales, we're able to enable access for researchers proposing projects, and anyone can join this consortium so that they can propose a project. We're able to enable access to data very quickly, much more quickly than is traditionally the case with this sort of thing. So there were a few projects of relevance to mental health going on using these data sets. There are some general ones around methods, high throughput phenotyping approaches, improving methods to minimize bias with respect to ethnicity. And then there's stuff on antipsychotic prescribing. There's some stuff on intellectual and developmental disabilities, on treatment and mortality after acute MI amongst people with severe mental illness, and on psychosis risk following COVID-19 infection and vaccination. I'm sure there's a huge number of other questions that could potentially be addressed. So, but at least we've been able to encourage some using our generic expansion. And now I want to just show you very quickly a few examples of how this has enabled large-scale research, which these examples have a cardiovascular twist because the mental health examples I've showed you haven't yet delivered results. So here you can just see that by bringing different data sets together, you find diseases that cannot be picked up through any single source, and you find them in large numbers in a relatively short period of time when you study a large population here, the whole population of England. Here you can see exactly the same for COVID-19 infection status. You can't just look at the test data, you can't just look at the hospitalization data, you have to look at all these different data sources to pick up the individuals with infection. I don't think this is so relevant anymore because nobody's testing that much. When it's a bit patchy, and when they do, they certainly don't tell anyone, they just certainly don't feed it back into any system. But this was certainly very important during the first, second, and third waves of the pandemic for picking up infection status. And then, as I was arguing earlier, it's possible to, and this is a study that was led by Jonathan and his group from Bristol, but in collaboration with others, that when you have very large numbers of individuals here, all adults in England and Wales, you can study over long periods of time. You can split by hospitalization and not status. It was also possible to look across different age groups, ethnicities, so to observe patterns in the data, but essentially here showing a very large increase in risk of stroke, heart attack, pulmonary embolus, and DVT following exposure to COVID-19 infection, even more so in those who are hospitalized, and falling more slowly in those individuals, falling more slowly for people with further venous outcomes, and not disappearing completely out to the period of time that this was studied, so out to 44 weeks after infection. So actually very important results for policy makers and people sort of thinking about healthcare management in the long term. And then similarly, with a very large population like this, here, the whole of England, you can find rare events. So this is an ideal sort of resource for studying rare adverse events following COVID-19 vaccination. And I think you know these results, which showed problems with AstraZeneca with these rare blood clots. The AstraZeneca vaccine, I should say, not the company. And then here you can see some of the insights that have started to emerge from using the medicines data, not really used before by the research community across all three countries, in England, Scotland, and Wales. So these sorts of data had been looked at in Scotland and I think to some extent in Wales as well before, but dispensed medicines data had never been looked at in England before. So it's possible to show these patterns of big dips in prescribing of cardiovascular risk prevention medications, suggesting that people weren't pitching up, weren't getting their risk factors picked up or treated, and the impact on new cases of disease can be modeled, as you see there. So these are some of the insights that have started to emerge from pulling together these data sets, putting them together and enabling researchers to access them and do really good things with them. Important to mention that all of the code that goes into generating those studies is all preserved so it can be reused in new pipelines. A lot of the pipelines for these research studies are common, and it's all made available in the public domain. So I will whiz through very quickly our other themes. The imaging one is probably the least relevant here, but we have a lot of interest in personal monitoring data. We're working very closely with Richard Dobson, who many of you will know, because he's been a champion of this work in the context of mental health research, to look at how personal monitoring data, people can provide consent for use of their data and for linkage of it to their NHS records through an app. So we're doing some work with him on that and a range of other things. Lots of work on computable phenotypes, like you guys feeding into the HDA UK phenotype library. And of great interest as well is this need to link disease-specific cohorts to health-linked data, health data. So there are loads of cohorts recruiting people with cardiovascular disease and diabetes. I'm quite certain the same is true for patients with mental health disorders. There are population cohorts as well, like UK Biobank. Their needs are being met by the longitudinal linkage collaboration. The needs of disease-specific cohorts in partnership with similar endeavors need to be met. And so we've been putting in place some infrastructures for helping with that. And that's going really well, using a similar platform to the LLC and working in partnership with colleagues at the University of Swansea and the UK CERT platform. And then the area of data-enabled trials I alluded to earlier, and we're working mainly with the cardiovascular clinical trials community, but a lot of the work we're doing docks into the more generic clinical trials theme for HDA UK more broadly. And I would say this sort of work is also, of course, highly relevant to mental health and this type of mechanism for running trials. So just a very quick plug finally for our data science catalysts. Once you've started to build out some infrastructures and some institutionally agnostic platforms and some ways of providing those, it often makes sense to mimic them or parallel them for other disease-specific communities. So we've been working with these charities who've invested some additional funds to enable us to do this. We're going to then move beyond the kind of cardiovascular, cardiometabolic area, do the same with Asthma Lung UK. And I've been discussing a little bit with Anne about how that might be a relevant mechanism to think about for mental health. And that's me. Thank you very much.
Thank you. We're very much working on the mental health catalyst.
Come and sit here. This is the comfy chair bit.
Questions? I can see one at the back. I don't know if the mic, well, middle. Thanks so much, Cathie.
Thank you very much indeed, Graham Murray from Cambridge. So, I mean, it's absolutely wonderful. A question, there are many there are quite a few different large data sets about English health. It's hard to know them all if you're not a total expert. I'm sure you know them all, but I don't know them all. I know there are some that are quite expensive as a researcher to use. Q Research, CPRD, I was really surprised at how many tens of thousands of pounds they charge me if I want to use their data. Could you comment on what the costs, how you compare to how this data set compares to those large data sets? What are the costs, the barriers as a researcher to getting access to these data?
Yeah, I mean, so just briefly, so there are two resources that broadly can cover the whole of England if you're interested in doing something across the whole population, which may or may not be relevant, that are low cost currently for any COVID-related research in particular. So there's this one, which is facilitated by the BHF Data Science Centre, and then there's Open Safely, and Jonathan Stern can actually speak to both because he's used both and has researchers using both. Currently, with additional investments, we've been providing access to the data and some of the sort of data curation management support that's required around that for free, provided people can bring themselves and make the effort to propose a project and are happy to interact with the consortium and play by the rules. And I think it's been similar for Open Safely. We're now, because we can't use the BHF money to invest in research that doesn't have a cardiovascular focus, and the financial year end has meant that we don't have the resources anymore to support all of those other areas. We can still support them, like we still have the approvals in place to support them and will do for the foreseeable future, but we're having to cost recover the costs of having people having a seat at the table. So that the costs for that are about £800 a month for access to the data if your project is not very cardiovascular focused. But happy to discuss offline the details of that.
There's another question here from Andrew, I guess.
It's not a very scientific question. It's really, whenever your logo comes up, I think it's intriguing to think about the possibilities of working with charitable organisations and co-partnering on a project. I mean, for us, it would be possibly an MQ data mined mental health. You know, that's really attractive. And I just wondered if you could say a little bit more about the benefits of partnering with a charity and how you might go about thinking about leveraging the advantages of both of those funding streams.
Yeah, so I can tell you how it's worked with Diabetes UK, Stroke Association, and is likely to work with Asthma Lung UK as an example of a sort of less cardiovascular one. So here, Diabetes UK heard me talk about what we were doing very early on and were keen to think about a partnership because they hadn't bid in the end for the hub programme. So they felt they sort of thought about what they would like to do. They saw what I was saying and thought, well, we'd like to do that. We don't have £10 million. So we spoke to them about how diabetes was clearly an area of interest for the BHF. If they wanted to invest in some leadership and building on top of what we were already doing, then we could perhaps think about a mechanism. It took quite a long time to talk it through for a relatively small investment. So Diabetes UK have invested 300k over 3 years with the hope that there might be some sort of sustainability option after that, which we're working on. And that allowed us to appoint an associate director, Ewan Pearson, who's great because he's really well connected with the community. It's allowed us to run a funding call to fund people's time to work in the environment and to buy out some of our data science time to focus on getting the diabetes data all sorted out, and a number of other activities that Ewan is leading and some project management time. So it can't support masses, it certainly can't support all the research projects, but it can support some of the crucial enabling layers by building on top of what already exists. That was a really good place to start because there's a lot of overlap in interest between those two charities. We've done something very similar with the Stroke Association here, investing £500,000 over 5 years. Asthma Lung UK, we will do something very similar. What we won't be able to do is directly invest the BHF monies in supporting that, but you can sort of start to see how the more of these verticals that build on this kind of institution agnostic platform, the more you can still build on top of a common infrastructure, and you have to invest a lot less to get a lot more out. So there'll be a similar model for Asthma Lung UK. So and we're working on actually something probably a bit chunkier in the area of dementia because it's something that Gates is interested in. So obviously they've got quite a lot of money to burn. So I think it's a good way for charities. I mean, I don't know the people at MQ terribly well. I'm sure they're in the room, but I know that you have been fantastic champions of data science. You probably don't have the sort of money to spend that charities like BHF do. I think this sort of mechanism potentially works very well.
Okay, we've got time for one final question.
Thanks. So if practically a researcher here had a mental health question that wasn't related to cardiovascular disease, and say we wanted linkage between CPRD, HARES and Biobank, if we go to the HDR UK website, are we able to get in touch with you and work on a way to develop that? Say if we had resources for £800 a month.
So this won't sort out a linkage between CPRD, HES and Biobank, but it'll sort out, but it may well be that the linkages we have in place, which are from population-wide health, so primary and secondary care and death and blah, 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 all these things, across England and actually Wales and Scotland. So depending on if your question is non-cardiovascular, you can do research in England as long as it has a COVID relationship. And I'm happy to discuss with you offline exactly what that means and how it would work. But yes, roughly speaking, it would cost in that sort of ballpark. Yeah.
Thank you.
Okay, I'd like to extend our thanks to Cathie because I think you've brought a whole new world to some of the people in this audience, and hopefully she'll be there to answer some questions during coffee. But
I will do, and please do get in touch with us. You know, if you want to ask questions to explore ideas in a bit more depth, we're very happy to have those conversations with you.
And coffee is served in the room from before.
Thank you.